Welcome to the Deep Dive, the show where we take a mountain of information and distill it down into the essential insights you need to be truly well-informed. Today, we're not just dipping our toes in, we're plunging headfirst into a field that touches countless lives worldwide. The intricate world of gynecologic surgery. It's an area of medicine that is incredibly prevalent, vital, and frankly, profoundly fascinating in its precision. Our mission today is to equip you with the foundational knowledge that truly defines an elite professional in this space.
That's exactly right. Think of this deep dive as your express shortcut to a professional level understanding, meticulously curated from SABISTON Textbook of Surgery, which is, a definitive gold standard resource in the field. This isn't a superficial glance. We're really going to uncover the anatomical intricacies, the common diseases women face, and the sophisticated surgical procedures used to treat them. You'll gain a grasp of details that really matter, from subtle anatomical nuances that can make or break a surgery, to the precise implications of different techniques. By the end, you'll feel like you've truly mastered this information, ready to engage with the topic at an entirely new level.
Okay, let's unpack this. To truly master gynecologic surgery, we have to start at the very beginning, the incredibly detailed world of female reproductive and pelvic anatomy. And we'll begin at the external structures, moving inwards with the vulva.
Exactly. When we talk about the vulva, we're referring to the main external structures that protect the internal organs and play a crucial role in sensation. Picture the mons pubis first. It's that soft, fatty tissue that cushions the pubic bone. What's interesting here is how it subtly guides us to the larger outer folds, the labia majora, right where it splits. This, seemingly minor detail actually helps surgeons orient themselves quickly.
Right, a landmark.
Yeah.
And nestled inside those larger folds, we find the labia minora. They're separated from the labia majora by what are called the interlabial sulci. Up front, these labia minora actually come together to form the clitoral hood, or the prepuce, which then covers and protects the highly sensitive clitoral glands. It's all incredibly interconnected, kind of like a beautifully designed natural shield.
Indeed it is. These labia then frame a central area known as the vestibule. This vestibule is home to two critical openings, the vaginal introitus, which is the opening of the vagina, and the urethral meatus, where urine exits. This whole area has a clear boundary, the heart line. And initially, the vaginal introitus is often partially covered by a thin membrane called the hymen, which, typically ruptures through everyday activities like exercise or tampon insertion or, of course, intercourse.
Okay. And within that vestibule, there are a couple of really important glands that often come up in surgical discussions.
Yeah.
Because they can develop specific pathologies, right?
Yes, exactly. We have the Bartholin glands located posteriorly to the right and left of the vaginal opening. What's truly fascinating here is their biological homology to the male bulbourethral glands, showing a shared developmental blueprint, basically.
Ah, interesting.
Their primary function, secreting mucus specifically for vaginal lubrication, especially crucial during sexual arousal.
Okay. And the other set.
And then, just anteriorly to the right and left of the urethral meatus, you discover the Skene glands. These are also quite remarkable because they're considered homologous to the male prostate gland.
Wow. Okay.
Oh. Yeah, like the Bartholin glands, they produce secretions for vaginal lubrication with sexual arousal. So, two distinct sets of glands, each with a male counterpart, playing a vital role in natural lubrication.
Now, zooming out a bit, these external structures are all precisely mapped within a larger anatomical region called the urogenital triangle. This forms the anterior portion of the perineum. So if you visualize it, its apex points forward to the symphysis pubis. And its base is formed by an imaginary line drawn between the ischial tuberosities, which are your sit bones, basically, posteriorly.
Right. And beneath these external structures lies the urogenital diaphragm. Think of it as a significant fascial and muscular shelf extending between the pubic bones. It's incredibly important because it's a structural gateway, penetrated by both the urethra and the vagina. The key muscles within this triangle include the deep and superficial transverse perineal muscles, providing structural integrity, and the paired ischiocavernosus muscles that cleverly cover the crura of the clitoris, along with the bulbocavernosus muscles, which wrap around the erectile vestibular bulbs on either side of the vaginal introitus. These muscles are vital for support and function.
That's a lot of intricate layering. When we think about blood supply to this area, the source material points out that it's predominantly nourished from a posterior direction. The main player here is the internal pudendal artery.
That's the one. This artery actually originates deep within the pelvis from the internal iliac artery, then takes quite an impressive journey, passing through a specialized fascial tunnel, almost like a protective conduit, called Alcott Canal.
Alcott Canal, right?
Once it emerges, it sends its anterior branches directly to supply the urogenital triangle.
But it's not the only arterial source, is it?
No, not at all. The mons pubis at the very front receives its blood supply from the inferior epigastric artery, which is a branch of the femoral artery. And laterally, the external pudendal artery, also arising from the femoral artery, supplies the lateral aspects of the vulva. Venous return and lymphatic drainage generally follow the arterial paths, ultimately draining into the internal iliac and femoral veins. Pretty standard pattern there.
And when it comes to nerve supply, the internal pudendal nerve is absolutely key.
Dominant player, yeah. It originates from the S2 to S4 anterior rami of the sacral plexus, deep in the spinal cord, and much like its arterial counterpart, travels through Alcott Canal alongside the artery and vein. Its anterior branches then provide sensory and motor innervation to the external genitalia, giving sensation and control.
Okay, but there are others too.
Additionally, yes, the mons pubis and the anterior labia receive sensory innervation from the ilioinguinal and genitofemoral nerves. These originate higher up from the lumbar plexus. They travel through the inguinal canal and exit via the superficial inguinal ring. What's crucial to remember here for surgeons is a common anatomical variation. All these paired nerves often cross the midline, providing at least partial innervation to the opposite side.
Oh, interesting. So, like, left side might feel a bit from the right nerve?
Potentially, yeah. And furthermore, the visceral efferent nerves, which are specifically responsible for clitoral erection, are derived from the pelvic splanchnic nerves and reach the external genitalia by passing through the urogenital diaphragm with the urethra and vagina.
So, as a surgeon, given all this crisscrossing and intertwining, you need to be incredibly aware of this variability in both vascular and neurologic direction, right? It's not a simple straight line path for blood and nerves. They truly interlace.
Absolutely. That seems like a really important surgical cognizance point, especially for delicate dissections. Understanding that variability is paramount for safe and effective dissection in this highly sensitive and functional region. It's where the textbook knowledge truly meets real-world patient safety.
Okay, got it. So let's transition from the external view to the complex internal reproductive anatomy. We're moving from those distal structures proximally: the vagina, cervix, uterus, fallopian tubes, and ovaries.
All right. Now, what's immediately fascinating from the source material is the dual developmental origins here.
Yep, tell us about that.
The lower portion of the vagina actually develops from the endoderm of the urogenital sinus, like a common developmental ancestor with the urethra and vulvar structures. But the upper portion of the vagina, along with the cervix, uterus, and fallopian tubes, develops from a completely different source, the Mullerian ducts.
And why is that dual origin so significant?
Well, it's incredibly significant because it means that failures in the fusion of these Mullerian ducts as they migrate medially or even incomplete development can lead to a wide spectrum of malformations. Think uterus didelphys, bicornuate uterus, malformations throughout the uterus, cervix, and fallopian tubes. It's a direct illustration of how embryonic processes directly dictate adult anatomy and can predispose individuals to specific pathologies that surgeons must understand and correct.
That makes sense. So let's start with the vagina itself. Describe its structure for us.
Okay. The vagina is an incredibly flexible and expandable fibromuscular tube designed for both passage and adaptation. At rest, it's typically flattened, and interestingly, in an upright woman, it lies mostly in a horizontal plane.
Horizontal. Okay.
Yeah. Its walls are composed of several distinct layers. From the inside out, you have the mucosa, which is a stratified squamous epithelium, providing a protective lining. Then the lamina propria, a dense layer of collagen and elastic tissue that houses the vascular and lymphatic supply. Next, a robust muscular layer responsible for its elasticity. And finally, an areolar connective tissue layer that's richly supplied with blood vessels, allowing for its incredible flexibility and support within the pelvis.
And its blood supply? Seems like it would need a good one.
It does, primarily from the vaginal artery, which is a direct branch of the internal iliac artery. What's notable here is not just one artery, but an extensive network of multiple anastomoses, essentially, cross connections with other arteries, including the uterine, internal pudendal, inferior vesical, and middle hemorrhoidal arteries. This rich, interconnected supply ensures robust blood flow.
Okay, and nerve supply?
Nerve supply is derived from the autonomic nervous system within the lumbosacral plexus, specifically nerve roots S2 to S4, culminating in the pudendal nerve. a crucial distinction for surgeons to understand. The vast majority of sensory innervation, meaning where you feel touch or pain, is concentrated in the distal or lower part of the vagina, with very little nerve density in the upper part.
That has huge implications for patient experience during various procedures, I imagine, like informing where sensation might be felt or where a block might be most effective.
Precisely.
Okay, next up, the cervix. It's often described as the narrow distal part of the uterus, palpable at the upper vaginal canal. Visually, it's typically round, sometimes described as donut-like, composed mostly of tough, fibrous tissue, and usually averages around 3 centimeters in length. It has a central canal, the aulas, which is the passage to and from the uterine cavity.
Allows for menstrual flow and sperm passage.
Right.
And critically, the cervix is home to the transition zone. This is a dynamic area where the smooth, protective squamous epithelium found on the vaginal portion of the cervix, the ectocervix, transitions to the glandular mucus-producing columnar epithelium of the cervical canal, the endocervix.
And that's the key spot for problems sometimes.
Exactly. This zone is profoundly important in gynecologic health because it's the primary site where cervical intraepithelial neoplasia, or the CIN, the precancerous changes, originates. The columnar epithelium itself produces mucus, which changes in texture and volume based on hormonal influences and plays a key active role in facilitating sperm transport into the uterus.
And its blood supply, how does that work?
The cervix receives its blood from a descending branch of the uterine artery located laterally at the 3 and 9 o'clock positions. These are key surgical landmarks. Additionally, you have the azygos arteries, which run in the middle portion of the cervix along its anterior and posterior axis. These also have multiple anastomoses with the hemorrhoidal arteries, again ensuring a robust, redundant blood supply.
Innervation.
This primarily comes from the parasympathetic system, originating from the lumbosacral plexus, specifically S2 to S4, with the highest concentration of nerve endings and thus sensation in the endocervical region.
Okay. So procedures deeper in the canal might be more sensitive?
Generally, yes, more so than on the outer surface.
Okay. Moving up from the cervix, we arrive at the uterus. This is an intraperitoneal muscular organ nestled posterior to the bladder and anterior to the rectum within the pelvic cavity. It's held precisely in place by several crucial ligamentous structures that provide both support and define surgical spaces.
Indeed. You have the broad ligaments, which are folds of peritoneum extending laterally from the uterine body and becoming continuous with the pelvic peritoneum, essentially draping over the reproductive organs. Then there are the round ligaments. They originate at the upper lateral aspects of the uterus, the uterine cornua, travel laterally through the broad ligament, exit the inguinal ring, and ultimately terminate in the labia majora. Think of them like guy wires, providing anterior support. The cardinal ligaments are robust structures attaching laterally to the pelvic diaphragm and fusing medially with the vaginal endopelvic fascia, providing absolutely crucial support at the level of the cervix. It's paramount for surgeons to know that the uterine arteries, the main blood flow, travel directly within these cardinal ligaments, making their precise identification vital during surgery.
Right. Critical point.
And finally, the uterosacral ligaments originate at the upper posterior cervix and arch backward to attach to the third sacral vertebra, framing the rectum. These ligaments provide essential posterior support and are key anatomical landmarks for pelvic floor reconstruction.
In terms of size, a non-pregnant uterus typically weighs between 40 and 80 grams, usually smaller in prepubertal and postmenopausal women compared to reproductive aged women, reflecting hormonal influence. And like other visceral peritoneal organs, it has 3 distinct layers.
Correct. The outermost layer is the serosa, which is very thin and continuous with the broad ligaments and pelvic peritoneum, essentially a protective outer wrapper. The middle layer, the myometrium, is the workhorse of the uterus, composed of thick, smooth muscle arranged in 3 distinct layers, capable of powerful contractions. And the inner layer, lining the uterine cavity, is the endometrium. This is a mucous epithelial layer whose thickness varies significantly with hormonal influences throughout the menstrual cycle. It's the layer that sheds during menstruation and where a fertilized egg implants.
Blood supply to the uterus comes from 2 major sources: the uterine arteries, which branch directly off the internal iliac arteries, and the ovarian arteries,
Which, surprisingly to some, originate much higher up, directly from the abdominal aorta, traveling adjacent to the ovary towards the uterus. This dual supply ensures remarkable vascular redundancy.
and its innervation,
Yeah.
also dual.
Also dual, yeah. Managed by both the sympathetic nervous system via the hypogastric and ovarian plexuses and the parasympathetic nervous system from the lumbosacral plexus S2 to S4. What's also key to note is that afferent fibers from the uterus, which carry sensory information like pain back to the spinal cord, travel with the sympathetic innervation within the lumbosacral plexus at levels T11 to T12.
Ah, okay. That becomes very relevant in understanding and managing uterine pain.
Exactly.
Then we have the fallopian tubes, or oviducts, originating at the upper lateral aspect of the uterus, the cornua, and extending laterally about 10 to 14 centimeters, coiling around the ipsilateral ovary distally. They have 4 distinct anatomical sections, each playing a specific role in egg transport and fertilization.
That's right. The first is the interstitial part, which is quite short, only 1 to 2 centimeters, and actually traverses within the uterine wall itself, completely surrounded by myometrium. Next is the isthmus, measuring around 4 centimeters, which is notably narrow and the most muscular region of the tube as it leaves the uterus. The ampullary region is wider, typically 4 to 6 centimeters, and has a winding, tortuous course. This is critically important because it's typically where fertilization occurs.
Meeting spot.
Usually, yes. Finally, the infundibulum is the funnel-shaped end, mostly composed of delicate, finger-like projections called fimbriae that extend out from the tube and actively sweep over the ovary to capture the egg.
And these tubes, like the uterus, are also made up of several layers.
Yes. The inner lining, the mucosa of the tube, consists of different types of epithelial cells, including ciliated cells that help move the egg along, and secretory cells, with the precise ratio varying by region. Beneath the mucosa is the lamina propria, then a muscular layer that helps propel the egg, and finally the adventitial layer, which is adjacent to the peritoneal cavity. Their blood supply travels efficiently through the mesosalpinx, a fold of peritoneum originating from branches of both the ovarian and uterine arteries, and they receive innervation from both sympathetic and parasympathetic nervous systems via the uterine and ovarian plexuses, coordinating their delicate movements.
Last but certainly not least for internal anatomy, the ovaries. These are paired, oval-shaped organs, typically 2 to 3 centimeters in diameter, and they're positioned laterally, just inferior to the pelvic brim, near the infundibulum end of the fallopian tubes. These are the powerhouse organs producing eggs and hormones.
Exactly. Their developmental association is quite interesting as they develop from the gonadal ridge right adjacent to the mesonephric duct. This illustrates the close developmental ties between the urinary and reproductive systems, a shared embryonic past. The ovaries are connected to the uterus by the uterovarian ligament, which, importantly, contains an anastomotic blood supply between these two crucial structures. They're also held in place by the posterior leaf of the broad ligament and, significantly, the infundibulopelvic ligament, or IP ligament. This travels down the lateral side wall and contains the major ovarian blood supply, making it a key surgical landmark for removing the ovary.
Okay. And the ovary itself has distinct sections.
3 distinct sections: an outer cortex where the oocytes mature, a central medulla composed mostly of connective tissue and blood vessels, and the hilum, which is where the mesovarium, a peritoneal fold, attaches and where vessels enter.
And they're packed with a variety of cell types essential for their multiple functions.
That's right. Within the ovaries are the oocytes, the immature egg cells, numbering 1 to 2 million at birth. The ovarian surface is covered by a specialized cuboidal epithelium. These oocytes mature inside small, fluid-filled sacs called follicles, which are located just under the surface epithelium. The central medulla, as you mentioned, is primarily composed of stroma and blood vessels.
And blood supply. From where?
Predominantly from the ovarian artery, a direct branch off the abdominal aorta that travels along the lateral abdomen and pelvis within the infundibulopelvic ligament. There are also numerous anastomoses, or connections, between the ovarian and uterine arteries within the mesovarium, again providing a robust and redundant blood supply. Innervation also travels via the infundibulopelvic ligament, including autonomic and sensory nerve fibers from the ovarian, hypergastric, and aortic plexuses, coordinating ovarian function.
So we've walked through the primary female reproductive anatomy, both external and internal, in impressive detail. It really sets the stage. But for surgeons, truly mastering this field means understanding other crucial pelvic anatomical components that define surgical spaces and house vital structures. Let's pivot to those, starting with the anatomic spaces.
Yeah, these are essentially potential pathways or highways that become incredibly important for surgical navigation, especially when the normal anatomy is altered by disease or prior surgery.
Makes sense. So what are the key ones?
Understanding these potential spaces is foundational for a surgeon's ability to operate safely and effectively. We have two key lateral retroperitoneal spaces, meaning they are behind the peritoneum and to the side: the paravesical space and the pararectal space. The paravesical space is bordered by the external iliac artery laterally, the bladder medially, the pubic symphysis anteriorly, and the cardinal ligament posteriorly. A surgeon skillfully enters this space by dissecting between the external iliac artery and the superior vesical artery.
Okay. And the pararectal space, similar idea.
Similar idea, different boundaries. That one is bordered laterally by the internal iliac artery, medially by the ureter and rectum, posteriorly by the sacrum, and anteriorly by the cardinal ligament. Entry involves carefully dissecting between the larger vessels laterally and the more delicate ureter and rectum medially. What's critical to note, and a key surgical pearl, is that the cardinal ligaments actually act as a partition, separating these two lateral retroperitoneal spaces, the paravesical and pararectal spaces. Identifying this ligament is key to navigating both.
Got it. Cardinal ligament as the divider. Beyond the lateral spaces, we also have important anterior to posterior spaces: the retropubic, vesicovaginal, rectovaginal, and retrorectal presacral spaces.
Right. And the source material emphasizes that meticulously developing these spaces during surgery truly facilitates the identification of critical pelvic structures, which is especially vital if the normal anatomy is distorted by tumors, adhesions, or prior surgeries. It's like clearing a path to see the crucial landmarks.
Indeed.
Next, let's talk about vascular structures, which are, as you can imagine, an immediate and absolutely crucial concern for surgeons, given the risk of bleeding.
Oh, absolutely paramount. The common iliac vessels are a key landmark. They bifurcate, or split, at the pelvic brim into the external iliac and internal iliac vessels. The external iliac vessels continue under the inguinal ligament to become the femoral artery and vein supplying the leg, while the internal iliac vessels course along the pelvic sidewalls, supplying much of the pelvis.
And the internal iliac artery is particularly important here, bifurcating into an anterior and posterior division. What's striking is that most of the arterial supply to the female pelvic structures, like the uterus and vagina, actually comes from branches of that anterior division.
This is a major point and a critical piece of surgical strategy. The ligation of the anterior division, essentially tying off a portion of it specifically distal to where the posterior division branches, is a technique frequently employed in dire cases of excessive pelvic hemorrhage when other methods of bleeding control are insufficient.
A life-saving maneuver.
Can be, yes. Key branches stemming from that anterior division include the uterine, vaginal, inferior, middle, and superior vesical arteries, supplying the bladder, and the middle rectal artery. Other vital branches include the obturator, inferior gluteal, and pudendal arteries. And let's not forget the ovarian arteries, which, originating directly from the aorta high in the abdomen, provide another significant and distinct vascular source to the ovaries and uterus.
So many pathways to be aware of, and so many points of potential major blood flow. Now let's look at the intricate network of neurologic structures.
Okay. The lumbosacral nerve plexus, a complex web spanning from nerve roots T12 down to S4, is the major source of nerve structures in the pelvis, branching out to supply both sensation and motor function.
Right. What are the main nerves coming out of that?
From this plexus, you have primary motor nerves, like the femoral nerve, responsible for leg extension, the sciatic nerve, which powers much of the leg and foot, and the obturator nerve, controlling inner thigh muscles. And then, equally important are the sensory nerves, including the iliohypogastric, ilioinguinal, genitofemoral, lateral femoral cutaneous, femoral sciatic, and pudendal nerves. It's truly eye-opening to understand what happens if these are injured, as per the source material.
Absolutely. This is where the textbook truly highlights the direct consequences. For instance, the ilioinguinal nerve has no motor function, but provides sensory input to the groin and symphysis. If injured, a patient might experience sharp burning pain radiating from the incision site to the groin or symphysis.
Right. And then there's the femoral nerve, which is critical for hip flexion and knee extension. An injury here could mean a patient struggles to climb stairs, a significant functional deficit.
Or consider the obturator nerve, primarily motor, controlling thigh adduction. Injury might cause only minor walking problems, but it's still a concern.
And the sciatic nerve, originating from L4S3, is a very big one. It governs hip extension and nearly all foot movements. Injury here can be devastating, leading to a foot drop or a cavus deformity of the foot where the arch is abnormally high. This detail underscores the surgeon's constant vigilance.
And that table of nerve injuries is so precise in its implications. The source states that nerve injuries occur in about 1% to 2% of gynecologic cases. Rare, but not unheard of.
Right, exactly. The most common ones injured are precisely those we just highlighted. Femoral, ilioinguinal, pudendal obturator, lateral cutaneous, iliohypogastric, and genitofemoral nerves.
And the causes, often related to the surgery itself.
Often linked to surgical positioning, especially the lithotomy position where the patient's legs are raised, or incorrect use of self-retaining retractors that can compress nerves. Less commonly, it can be direct nerve transection, entrapment by suture, or even hematoma formation post-op.
But there's good news usually.
Fortunately, yes. The majority of these neuropathies resolve with conservative management and physical therapy, which is reassuring for patients, but careful intraoperative awareness and prevention remain paramount.
Okay. Moving on to urinary tract structures, specifically, the ureters and bladder. These demand an incredibly strict and meticulous level of attention during most gynecologic procedures because of their intimate anatomical relationship to the reproductive organs.
Indeed. The ureters are critical tubular structures that course retroperitoneally down the lateral pelvic walls, transporting urine from the kidneys to the bladder. A key anatomical crossing occurs as they pass over the common iliac arteries at the pelvic brim.
Right near the ovaries.
Exactly. At this specific point, they are in close proximity to the ovaries, so surgeons must exercise extreme, almost obsessive, care to properly identify and avoid them, especially during ligation of the ovarian vessels, which is a common step. The ureters then continue along the peritoneum, passing under the uterine arteries. This is another high-risk crossing, the water under the bridge mnemonic. And finally, traverse into the bladder laterally in an oblique fashion. This intimate relationship means the ureter is consistently at risk for damage during clamping, incision, and ligation of the uterine vessels, the cardinal and uterosacral ligaments, and when working near the vaginal corners.
So, when a surgeon identifies that the ureter is particularly vulnerable due to a mass or altered anatomy, what's a common protection technique?
A very useful and widely employed technique is meticulously dissecting the ureter off its peritoneal attachment and then isolating it with a small, flexible vessel loop. This provides clear identification and a tangible separation, allowing the surgeon to visualize its path and protect it throughout the procedure.
Smart. And the bladder, also very close.
Very close. It's intimately involved with the anterior uterus, cervix, and vagina. During a hysterectomy, for example, the bladder must be meticulously dissected off these structures, creating a clear space. This often involves incising the vesicouterine peritoneum and identifying the vesicovaginal space between the bladder and vagina. This dissection can be particularly challenging due to scarring from prior C-sections, endometriosis, or even prior cancer treatments, making that delicate separation much more difficult.
And what are the stats on injury for these vital structures? Are they common?
Thankfully, no. Injuries to the ureters and bladder are reported to occur in less than 1% of patients undergoing major gynecologic surgery, which speaks to the high level of surgical skill and caution. To confirm an intact bladder and bilateral ureteral efflux, meaning urine flowing from both ureters into the bladder after high-risk procedures, cystoscopy is often utilized immediately postoperatively. This involves inserting a tiny camera into the bladder to visualize these critical areas.
Okay. Finally, for anatomy, we had the intestinal tract structures. The distal ileum, cecum, appendix, sigmoid colon, and rectum are all located near or within the pelvis, and their proximity means they require careful consideration and protection during gynecologic surgery.
Adhesions, often dense bands of scar tissue resulting from prior surgeries or inflammation, are a common concern. Surgeons must pay careful attention to luminalize these adhesions to restore normal pelvic anatomy before proceeding with any gynecologic procedure. These intestinal structures can also be involved by various gynecologic pathologies, such as large tubovarian abscesses, aggressive endometriosis, or large ovarian neoplasms. It's critical to carefully inspect the intestinal organs for any occult injury during a gynecologic procedure, which, thankfully, is reported to occur in less than 1% of patients.
And there's a test for that.
A useful intraoperative tool for detecting a subtle sigmoid injury is a bubble test, where the rectum is gently insufflated with air, the sigmoid is compressed to hold the air, and the pelvis is filled with saline or water to observe for any telltale bubbles indicating a leak.
That's an incredible amount of anatomical detail. It truly sets the stage for understanding the precision required in gynecologic surgery and the many structures a surgeon must always keep in mind. Now, let's transition into specific diseases and the surgical procedures for them, starting with common vulvar and vaginal surgical diseases.
Okay, first up, Bartholin gland cyst or abscess. This is a common and often painful condition that occurs when the greater vestibular glands, those lubricating glands we discussed earlier, become blocked. This blockage leads to mucus accumulation, causing obstruction and potentially developing into a painful abscess if infected. It commonly presents as a palpable vulvar mass on the lower medial labia majora. While some cysts are asymptomatic and found incidentally if infected, they rapidly become a painful, tender, and often debilitating abscess. Symptomatic cases almost always require surgical intervention.
So what are the primary surgical management options for these? Incision and drainage.
Yes, incision and drainage with placement of a word catheter. A small inflatable balloon catheter that keeps the incision open for drainage is one option. Or marsupialization. Marsupialization is typically indicated for recurrent infections or when the abscess is too large for simple incision and drainage, essentially creating a permanent new opening. Excision of the entire gland itself is rarely indicated due to the risk of significant scarring and pain.
Got it. Next, vulva intraepithelial neoplasia or VIN. This is a premalignant condition of the vulva, meaning it's abnormal cell growth that could become cancerous if left untreated.
Right. The classification system was updated in 2015 to a clearer two-tier system for classical VIN, low-grade squamous intraepithelial lesion, FHSIL, and high-grade squamous intraepithelial lesion, HSIL. There's also a separate category for VIN differentiated type, which behaves differently.
And the cause is often HPV.
The majority of LSIL and HSIL VIN are directly associated with human papillomavirus, or HPV, the same virus linked to cervical cancer. These HPV-related types tend to occur in younger women and are often multifocal, meaning they appear in multiple spots. The differentiated type, however, is less understood, often associated with inflammatory dermatoses like lichen sclerosis, seen more commonly in older women, and importantly, is not associated with HPV.
Symptoms.
Women with VIN might experience persistent vulvar hitching or pain, though remarkably, up to 40% can be completely asymptomatic and found incidentally during an exam. Diagnosis is confirmed by colposcopy using magnification, followed by targeted biopsy of suspicious areas.
Treatment depends on the grade.
Yes. For LSIL, observation or topical imiquimod, a cream, may be used. HSIL, however, typically requires active treatment, primarily with wide local excision or laser ablation. Due to persistently high recurrence rates, continued monitoring after therapy is absolutely essential.
Then we have vulvar cancer. While it's relatively rare among all gynecologic cancers, it unfortunately contributes significantly to overall mortality from reproductive tract cancers.
Yes, squamous cell carcinoma is by far the most common type, though rarer histologies like verrucous, basal cell melanoma, and extramammary Paget disease are also seen.
Risk factors.
Key risk factors include smoking, chronic HPV infection, a history of VIN, prior cervical dysplasia or cancer, chronic lichen sclerosis, and any form of immunodeficiency. Patients most commonly present with a persistent symptomatic nodular or ulcerative vulvar lesion, often noticed because of itching or bleeding. Treatment is highly individualized based on the clinical stage of the cancer.
And the treatment has evolved, right? Less radical
Yeah.
surgery now.
Exactly. For cancers confined to the vulva, traditional surgical resection involved radical vulvectomy, removing a significant portion of the vulva, along with bilateral inguinal femoral lymph node dissection. As you can imagine, this was associated with very high morbidity. However, less radical techniques, particularly sentinel node dissection, which we'll discuss more later, have been adopted to significantly reduce morbidity while maintaining excellent oncologic outcomes. For larger cancers, or those involving vital structures like the urethral opening, vagina, or anus, a combination of chemotherapy and radiation is often the preferred strategy to preserve function.
Moving inward, we have vaginal intraepithelial neoplasia, or VANE, another premalignant condition, this time affecting the lining of the vagina.
Like VIN, it's also classified with a two-tier system, LSIL and HSIL.
Symptoms. Risk factors.
Patients with VANE are often asymptomatic, discovered during routine screening, and risk factors are quite similar to VIN, including HPV infection. Management also mirrors VIN, but for HSIL vein, laser ablation is more frequently considered as a primary treatment than partial vaginectomy, largely because it's less invasive and preserves more vaginal tissue.
Which brings us to vaginal cancer itself, also quite rare compared to other gynecologic cancers.
Yeah, squamous cell carcinoma is the most common histology, with less common types including adenocarcinoma, sarcoma, and melanoma. Beyond the risk factors for vulvar cancer, a specific historical risk factor for certain types, particularly clear cell adenocarcinoma, is diethylstilbestrol, DES exposure in utero. Prior pelvic radiation exposure is also a risk.
How does it usually present?
The most common presenting symptom is often abnormal vaginal bleeding, sometimes postcoital followed by vaginal discharge, urinary symptoms due to bladder involvement, or pelvic pain. The most significant prognostic feature, determining outlook, is the stage of the cancer at diagnosis. The majority of patients are treated with a combination of radiation and chemotherapy. Radical hysterectomy with upper vaginectomy is a very rare surgical option, considered only for very select patients with small stage I cancer strictly confined to the vaginal mucosa, specifically in the posterior vaginal fornix.
A very common condition that impacts many women and their quality of life: pelvic organ prolapse. This is essentially the herniation or downward displacement of pelvic organ.
Right. Most commonly the bladder, causing the anterior vagina to bulge, which we call a cystocele. The cervix or vaginal cuff after hysterectomy, causing the apex of the vagina to descend. Or the rectum, causing the posterior vagina to bulge, a rectocele, all moving beyond their normal anatomical position.
What increases the risk for this?
Key risk factors include parity, meaning having given birth, increasing age as tissues lose elasticity, obesity due to increased intra-abdominal pressure, chronic constipation, and chronic obstructive pulmonary disease, COPD, both involving straining, and certain connective tissue disorders. Patients most commonly experience symptoms of pelvic pressure, a feeling of a bulge or something falling out of the vagina, or changes in bowel or bladder function.
And treatment. Conservative first.
Treatment depends entirely on the degree of prolapse and the patient's symptoms. Non-surgical options include pessaries, which are supportive devices, pelvic floor exercises and physical therapy, weight loss, smoking cessation, and local estrogen therapy. Surgical intervention is reserved for women who have either failed or declined these conservative management strategies and continue to be symptomatic.
And the ultimate goal of surgical repair for prolapse, what are surgeons aiming for?
The overarching goal is multifaceted: to restore the normal anatomy of the pelvic organs, and critically, to restore normal function to the anterior, posterior, and apical vaginal compartments. That means addressing bladder, bowel, and sexual function. For apical prolapse repair, the foundation, the most common procedures are abdominal sacrocolpopexy done open, laparoscopically or robotically, and 2 transvaginal approaches: sacrospinous ligament suspension and uterosacral ligament suspension.
How do these surgical options compare in terms of outcomes and patient recovery?
Abdominal sacrocolpopexy generally results in a lower rate of recurrence compared to transvaginal approaches, offering more durable results. But it's typically associated with longer surgical time and a slightly delayed return to normal activities. Long-term recurrence rates for all prolapse surgeries are approximately 25%, meaning about 1 in 4 women may experience some recurrence over many years.
And the transvaginal options?
Interestingly, there's no significant difference in long-term anatomical outcomes between uterosacral ligament suspension and sacrospinous ligament suspension, though reported failure rates over many years are around 62% and 70%, respectively. It's very common for women to have multiple compartments affected, so a comprehensive repair addressing each is often beneficial. Anterior and posterior colporrhaphy, fixing bladder and rectal bulges, are often not needed separately with an abdominal sacrocolpopexy, as the apical repair often helps correct those. However, they are more often performed with transvaginal reconstruction in conjunction with the ligament suspensions.
And for women who aren't ideal candidates for extensive reconstructive surgery, or who are no longer sexually active, there's another specific option: colpoclasis, basically closing the vagina.
Essentially, yes, obliterating the vaginal canal. This procedure can be a very effective solution for symptom relief without the higher surgical morbidity of complex reconstruction. Benefits include shorter operative time, very low recurrence risk, and similar patient satisfaction with symptom relief. This makes it a highly appropriate choice for older women with multiple medical comorbidities who are no longer sexually active and prioritize symptom relief. It's a pragmatic and often very successful approach for specific patient populations.
Now let's dive into the actual common vulva and vaginal surgical procedures themselves, starting with the immediate management of Bartholin gland issues.
Okay. For incision and drainage of a Bartholin gland cyst or abscess, the precise technique is crucial. Stabilize the cyst, make an incision over its center, specifically on the medial aspect, just outside the hymenal ring.
Not laterally.
Right. Common mistake is going too lateral. Use a hemostat to gently break up any internal loculations, irrigate thoroughly. Then, a small word catheter is typically placed for sustained drainage and reevaluated weekly. And because these are often polymicrobial, culture the fluid, especially check for MRSA and treat with appropriate antibiotics.
And for marsupialization when more permanent drainage is needed.
This goes a step further. Create an elliptical incision in the vestibular mucosa down to the gland wall. Incise the gland wall along that ellipse, evacuate contents. Then the key step. Suture the cyst wall to the vestibular mucosa using absorbable sutures. This creates a permanent epithelial-lined opening, reducing recurrence.
Next, wide local excision laser of the vulva, typically for VIN.
A wide local excision is a superficial excision, most commonly for HSIL VIN. Outline the lesion with typically 1 centimeter margins, maybe smaller near vital structures for cosmetic functional reasons. Incision depth is deliberately shallow, just 2 to 3 millimeters, removing only the epidermis. Deeper dermis isn't needed for pre-invasive disease. Reapproximate the defect with sutures.
What about the CO2 laser vaporization alternative? It sounds less invasive.
It is a valuable alternative, especially for multifocal disease, lesions near vital structures, or extensive VIN where surgery would be disfiguring. However, crucial point, laser is only used with low clinical suspicion for malignancy and confirmed no invasive cancer via biopsies.
Right, biopsy first.
Absolutely. Depth of ablation is precise. 1 millimeter on non-hair-bearing areas, 3 millimeters on hair-bearing areas, often guided by colposcopy for precision.
And for laser of the vagina partial vaginectomy for vein? Similar principles.
Similar. CO2 laser vaporization is generally preferred for newly diagnosed HSIL lane, easier, less risk to adjacent structures. Ablate the involved superficial vaginal dermis with a 1 to 2 centimeter margin. Partial vaginectomy, excising a portion of vaginal epithelium, is more common for HSIL vein patients with prior hysterectomy and recurrence after laser, or for larger lesions, usually done vaginally, excising the lesion with a 1 to 2 centimeter margin. Meticulous care needed to avoid bladder or colon injury. Reconstruction might be necessary.
Okay, let's discuss radical vulvectomy with sentinel node mapping and biopsy, or inguinal femoral lymphadenectomy for vulvar cancer, a much bigger operation.
Much more significant, yes. A radical vulvectomy can be total or partial, tailored to the cancer. Outline with the 2 centimeter margin, maybe smaller near vital structures. Unlike superficial excision, the incision here goes down beneath the subcutaneous tissue to the fascia of the urogenital diaphragm, aiming for deep, clear margins. Identify and ligate the clitoris and its vessels anteriorly, bulbocavernosus muscles, and internal pudendal vessels laterally, as needed. Amputate the specimen, mark for orientation, close in layers.
And the advancement of sentinel lymph node, SLN, mapping and biopsy. This is a huge leap forward in reducing morbidity, isn't it?
Absolutely transformative. This is now preferred for lymph node evaluation in early-stage vulvar cancer, lesions 4 centimeters. Preoperatively, inject radioactive isotopes subdermally around the lesion. A nuclear scan or SPECTI helps plan. Intraoperatively, use blue dye with the tracer significantly increases detection of the sentinel node, the first node draining the tumor.
What happens if no sentinel lymph node is identified, or the patient isn't a candidate?
Then a full inguinofemoral lymphadenectomy is performed. Incision parallel to and below the inguinal ligament. Remove all lymph node tissue between inguinal ligament, sartorius muscle, and adductor longus muscle. Crucially, preserve the great saphenous vein to decrease lymphedema rates. May open cribriform fascia for deep nodes. Place a drain, close in layers.
Finally, let's get into the specifics of pelvic organ prolapse procedures. We mentioned vault suspensions like the abdominal sacrocolpopexy, sacrospinous ligament suspension, and uterosacral ligament suspension.
Let's elaborate on the abdominal sacrocolpopexy. Highly effective. Can be open, laparoscopic, or robotic, concurrent with hysterectomy or post-hysterectomy. Key steps. Develop vesica-vaginal space, dissect bladder off anterior vagina, and rectovaginal space, dissect rectum off posterior vagina. Suture a Y-shaped mesh graft to anterior and posterior vagina. Incise peritoneum over sacral promontory. Secure graft anterior sacral ligament with permanent suture care to avoid middle sacral vessels. Reapproximate retroperitoneum over mesh.
And the sacrospinous ligament suspension, the most studied transvaginal procedure.
For this transvaginal approach, enter pararectal space through posterior vagina, dissect epithelium to ischial spine, Open rectovaginal space, palpate ischial spine. Place 1 or 2 sutures through sacrospinous ligament, carefully protecting pudendal vessels nerves, then through muscularis of posterior vaginal epithelium. Ligate using a pulley stitch to suspend the apex.
What about the high uterosacral ligament suspension?
Common transvaginal procedure, typically after vaginal hysterectomy. Pack bowels away, identify uterosacral ligaments. Pass 1 to 3 delayed absorbable sutures bilaterally through the ligaments, first near ischial spine, then more proximally. Hold sutures, critical safety check, cystoscopy. Ensure bladder integrity and bilateral ureteral efflux. No damage.
Always check the plumbing.
Always. Then pass tagged needles through anterior fascia epithelium, then posterior fascia epithelium at vaginal apex to suspend vagina anteriorly, posteriorly, and apically. Comprehensive support.
Now, for the more localized repairs, the anterior and posterior colporrhaphy, often done for bladder or rectal prolapse.
Anterior colporrhaphy starts with incising anterior vaginal epithelium to apex of cystocele, bladder bulge. Dissect epithelium off underlying pubocervical fascia laterally to pubic rami. Plicate, or fold and tighten, the pubocervical fascia in the midline using interrupted, delayed absorbable sutures from bladder neck to base. Provides bladder support. Excise excess vaginal skin if present. Close epithelium.
And posterior colporrhaphy. Similar concept for the rectum.
Exactly. Incise posterior vaginal epithelium vertically past rectocele, rectal bulge. Dissect epithelium off rectovaginal septum laterally to levator ani muscles. Plicate rectovaginal septum to midline with delayed absorbable suture. Tightens rectal support. Excess epithelium close with running suture. If perineal body is deficient, perform modified crown stitch to reattach bulbocavernosus muscles to transverse perineals and rectovaginal fascia, reconstructing support. Digital rectal exam at completion is mandatory. Ensure no rectal injury. And caution, avoid over-narrowing vagina or introitus.
Lastly, for prolapse, colpocalasis, the vaginal closure option.
Right. Most common is the Lefort partial procedure, used when uterus is left in situ. Key contraindication. Avoid in women at high risk for uterine and cervical cancer, as future sampling is impossible.
So, needs careful screening beforehand.
Thorough workup. Ultrasound, endometrial biopsy, pap smear. Procedure involves traction on cervix, incise and denude rectangular portion of anterior vaginal epithelium, plicate bladder neck, incise and denude similar posterior portion, reduce prolapse, reapproximate denuded walls, leaving bilateral epithelial-lined tunnels for drainage.
And for women who have had a prior hysterectomy.
For them, colpectomy with total colpoclysis, entire vaginal epithelium excised, reapproximate underlying connective tissue with serial purse string sutures until prolapse completely reduced. With both, extreme care not to bring closure too close to bladder neck can cause severe incontinence.
That's a truly comprehensive look at vulvar and vaginal conditions, and they're often intricate surgical solutions. Now let's shift our focus specifically to the cervix and its common surgical diseases and procedures. We start with cervical intraepithelial neoplasia, or CIN.
CIN is fundamentally a pre-malignant condition of the cervix, unequivocally caused by persistent human papillomavirus, or HPV, infection. While lifetime risk of HPV infection is staggering, like 80%, most are transient, don't progress. But persistent HPV, especially high-risk types 16 and 18, carries a high rate of progression to CIN and, if untreated, invasive cancer. Important timeline point. Average time from infection to invasive disease is generally over 15 years. Big window for detection.
So persistent infection is the key factor that increases risk. What are the identifiable risk factors for that persistence and for CIN?
Risk factors for acquiring HPV-CIN include early sexual debut, multiple partners, history of other STIs. Risk factors for persistent HPV include immunocompromised state and smoking. The truly transformative news is HPV vaccines, initially approved 2006, significantly reduce risk of warts and CIN. Gardasil 9, approved 2014, offers broad protection against 9 types. Powerful public health tool.
This brings us to cervical cancer screening, which has been an absolute game changer in women's health.
Absolutely. Pap smears over past decades dramatically decreased incidence and mortality in developed countries. Huge success. Most cervical cancer now is in low resource areas or inadequately screened women. Understanding HPV's role led to high-risk HPV testing becoming crucial, sometimes used alone. Current recommendations. Cytology alone every 3 years, age 21-29. Age 30-65, co-testing, cytology plus HPV, or HPV testing only every 5 years.
And what happens if screening comes back abnormal? How does the workup proceed?
ASCCP algorithms guide the workup. A colposcopic evaluation of the cervix using magnification with targeted biopsy of any acetowhite lesions areas turning white with acetic acid, especially those with abnormal vessels, is recommended. Biopsies now use a streamlined two-tier grading, LSIL and HSIL. Core principle. Early detection and treatment of premalignant conditions prevents cancer. HSIL lesions generally treated with loop electrosurgical excision procedure, LEEP, or cold knife combination, CKC. In resource-constrained areas, see and treat approaches are used to treat immediately without waiting for biopsy. Pragmatic lifesaver.
Then the most serious outcome, cervical cancer. Incidence declined significantly in developed countries due to screening vaccine, making it relatively rare in U.S., but still a major global issue.
Remains one of most common cancers worldwide, leading cause of morbidity mortality in developing world. Highlights disparities. In developed nations, often disproportionately affects low socioeconomic status and minority groups.
Histology.
Yeah.
Still mostly squamous.
Squamous cell and adenocarcinoma is most common. Squamous rates decreased, but increase in adenocarcinoma and adenosquamous carcinoma is seen in some countries, like U.S. New Challenge. Patients most commonly present with abnormal bleeding, irregular, heavy postcoital, unusual discharge, or pelvic pain. Diagnosis confirmed by cervical biopsy.
How is it staged, and what are the primary treatment approaches? Staged clinically, right?
Yes, unique in that it's staged clinically. Examaging, not surgically. Treatment depends on stage, early stage. Surgery equally effective as chemoradiation. Radical hysterectomy with either sentinel node biopsy or pelvic para-aortic lymphadenectomy is surgical choice for select patients unlikely to need adjuvant radiation.
The sentinel node biopsy seems like a big step forward here too, just as for vulvar cancer.
Truly transformative. Increasingly incorporated using blue dye or indocyanine green injected into cervix. Centicol studies showed impressive results, 98% identification, 92% sensitivity, 98% NPV, 0% false negative rate for high-grade disease. However, crucial recent research. Studies suggest higher recurrence risk for radical hysterectomy via minimally invasive procedures, especially if lesion 2 centimeter.
Oh, really? So maybe open is better sometimes now.
Significant reevaluation happening. Open approach may now be preferred in most instances for these larger lesions to ensure complete removal.
What about fertility preservation for younger patients?
For select patients wishing fertility, radical trachelectomy might be considered, highly specialized, typically for FIGO stage IA1 with LVSI, IA2, or IB1 disease, lesions equals 2 centimeters. For very microinvasive disease, simple hysterectomy or even conization may be an option, still being evaluated in trials. Locally advanced disease, chemo and radiation are more effective, the mainstay.
Now let's talk about the specific common cervical surgical techniques. First, conization or loop electrosurgical excision procedure.
LLP.
Both LEEP and cold knife conization, CKC, remove a precise cone-shaped portion of cervix for diagnosis and treatment of dysplasia. LEEP often done in office, local block. CKC usually in OR, needs more exposure, longer time. LEEP uses heated wire loop to excise transformation zone CIN. Common to do top hat excision second, deeper sample from endocervical canal.
And for CKC, the more traditional approach with the scalpel.
For CKC, hemostasis is critical.
Right.
Figure of 8 retention sutures at 3 and 9 o'clock ligate descending uterine artery branches. Apply Lugol solution to outline areas. Inject lidocaine epinephrine to reduce bleeding. Make circumferential incision around transformation zone lesion with beaver blade. Grasp specimen with Alice clamps for orientation. Amputate with scalpel or Mayo scissors. Marking stitch at 12 o'clock. Perform endocervical curettage above cone. Running lock stitch or Sturmdorf stitch may be done to avert canal, achieve hemostasis. Next, radical hysterectomy, radical trachelectomy with pelvic lymphadenectomy. Much more extensive, complex procedure.
Absolutely. Radical hysterectomy involves much more extensive excision. Uterus, perimetrium, surrounding tissue with nerves, vessels, upper vagina can be open, minimally invasive, or vaginal, less common for radical. Shared decision-making, crucial reapproach, given new data on minimally invasive risk for lesions 2 centimeters.
Right.
If open, transverse incision, Maillard-Cherney, often used for lateral exposure. Piver-Rutledge-Smith classification describes extent, class I simple to V, modified radical, type 3 most common today. Core principles: develop paravesical pararectal spaces, divide uterine artery veins, dissect bladder ureters off anterior cardinal ligament, Dissect rectal tissues off posterior cardinal ligament. Divide cardinal ligaments for adequate perimetrial sample margin. Ovaries usually spared premenopausally.
And the radical trachelectomy, the fertility-sparing option, sounds quite remarkable.
It is remarkable, highly specialized. Option for women desiring fertility with specific stages. IA1W LVSI, IA2 IB1, lesions equals 2 centimeters. Similar radicality, remove cervix, perimetria, upper vagina, but uterus body preserved. Place cerclage stitch, reattach preserved uterus to superior vagina, allows potential future pregnancy.
And what about pelvic lymphadenectomy, crucial for staging and treatment?
Usually done with radical hysterectomy trachelectomy for early stage, assesses node involvement. Para-aortic node resection not routine, especially if no pelvic metastasis evidence. Pelvic lymphadenectomy typically includes nodes lateral medial to external iliac artery vein, common iliac bifurcation to deep circumflex iliac vein. Also nodes from obturator space between external iliac vein obturator nerve. Para-aortic lymphadenectomy, when done, is bilateral removal lateral to common iliac artery aorta, bifurcation to at least inferior mesenteric artery, or higher for high risk.
We've covered a lot of ground on the cervix. Let's move on to the uterus and its common surgical diseases and procedures, starting with abnormal uterine bleeding, or AUB.
AUB is truly one of the most common gynecologic complaints in reproductive aged women. Huge impact. Broadly defined as bleeding excess of, or in addition to normal cycle, regular 24-38 days, duration 4 to 8 days. Old terms, menorrhagia, etc., replaced by Palm-Cohen classification system, established 2011, aims to precisely identify underlying cause, not just describe symptom. Very structured.
So break down Palm-Cohen for us. It sounds like a very useful framework.
It is. Palm groups structural entities diagnosed with imaging histology, polyps, lining growths, adenomyosis, lining in muscle wall, leiomyoma, fibroids, malignancy hyperplasia, cancer per cancer, Coe-Ein group, medical non-structural diagnoses, coagulopathy, bleeding disorders, ovulatory dysfunction, endometrial causes, lining issues, iatrogenic, meds treatments, not otherwise classified, key for guiding diagnosed treatment.
What's the initial workup a clinician would typically perform for AUB?
Comprehensive approach, detailed history, pelvic exam, tenderness, mass, uterine size, pregnancy test crucial, lab evil, thyroid, blood count, prolactin, maybe hormones, cervical cancer screen if needed, STI screen, pelvic ultrasound standard, coagulation disorder screen indicated if heavy bleeding since menarche, family history, on meds causing bleeding, or signs of systemic bleeding, nosebleeds, bruising.
And when is an endometrial biopsy, direct sampling of the lining, indicated?
Crucial for ruling out hyperplasia malignancy in high-risk patients. Women 45 plus with any increased abnormal bleeding need sampling. Women 45 with risk of unopposed estrogen, obesity, PCOS, persistent AUB, failed medical management, or high familial cancer risk should also be considered. Critical tool for early detection.
Shifting to a related but distinct and urgent concern, postmenopausal bleeding. Always abnormal, right?
Always considered abnormal. Any bleeding after menopause needs thorough evaluation. Most common cause is actually atrophy thinning lining vaginal tissue due to lack of estrogen, susceptible to inflammation infection. However, major concern driving evaluation is underlying malignant, pre-malignant condition. 19% of women with postmenopausal bleeding have endometrial cancer.
So investigation is key.
Absolutely. Other causes: benign polyps, fibroids, adenomyosis, meds, HRT, anticoagulants, initial evil. History, physical, pelvic ultrasound, often endometrial biopsy. Biopsy potentially avoidable if endometrial thickness 4 millimeters on ultrasound, low risk, but strongly indicated if 4 millimeters suspected focal lesion, poor visualization, or persistent bleeding despite normal ultrasound.
Next, uterine polyps or endometrial polyps.
Overgrowth of normal endometrial gland stroma. Benign finger-like projections. Can be sessile, flat, or pedunculated on stalk. Often have characteristic inner feeder vessel seen on Doppler sono, vary greatly in size. Common cause of AUB or postmenopausal bleeding, vast majority benign, but up to 5% can undergo malignant transformation, especially postmenopausally. Risk factors: age, increased estrogen exposure, tamoxifen, obesity, certain hereditary cancer syndromes. Also may increase risk of early pregnancy loss, interfere with implantation.
A hugely common one. Leiomyoma, uterine fibroids.
Most common benign gynecologic tumors, up to 30% women, up to 50% black women. Smooth muscle tumors in myometrium, classified by location using FIGO system, crucial for surgery. Type 0 completely intracavitary. 1 and 2 submucosal, 50% myometrial. 3, 4, 5 intramural within wall. 6 and 7 subserosal on outer surface, 7 pedunculated. 8 Schotterman, cervical parasitic, etc.
They can range dramatically in size and number, distorting the uterus.
Yes, small to huge, single or multiple. Diagnosed with pelvic imaging, ultrasound, or MRI. MRI often preferred for planning incisions, detailed location, number, vascularity, symptoms directly related to location size. Commonly abnormal bleeding, pelvic pain, pressure on adjacent organs. Treatment, medical or surgical, depends on patient desires, symptoms, fertility plans. Medical options often target bleeding, growth linked to ovarian hormones, grown reproductive years, regress with menopause. Other risks, family history, obesity, some dietary factors.
Then adenomyosis, often confused with fibroids, but distinct.
Defined by endometrial gland stroma within myometrium, muscle wall. Variant of endometriosis, often found together. Pathogenesis. Complex interaction between displaced endometrial cells and myometrium causes muscle hypertrophy, inflammation. Heavier, enlarged, tender uterus often results. Similarities to fibroids, angiogenesis, growth factors, often coexists. Commonly post-surgical diagnosis, but clinically suspected, sometimes seen on imaging, ultrasound MRI, heterogeneity, blurred junctions, cysts, and muscle. Adenomyomas are discrete focal masses.
And its prevalence. Who gets it?
Estimated 30% reproductive aged women. More prevalent later reproductive years, more common multiparous women. Symptoms: heavy, painful periods, irregular bleeding, painful intercourse, chronic non-cyclic pelvic pain, some asymptomatic. Treatment: medical, NSAIDs, hormonal contraceptives, or surgical hysterectomy if failed medical, no fertility desire.
Finally, for uterine diseases, endometrial, and other uterine cancers. Endometrial cancer is tragically the most common gynecologic cancer, incidence rising with obesity.
Other risks: age, diabetes, nulliparity, PCOS, unopposed estrogen tamoxifen use. Crucially, Lynch syndrome, hereditary non-polyposis colorectal cancer, carries up to 60% lifetime risk. Autosomal dominant genetic disorder, mutations in mismatch repair genes, MLH1, MSH2, MSH6, PMS2, highest risk with MLH1, MSH2. Endometrial often first cancer, also increased ovarian cancer risk. Prophylactic hysterectomy BSO should be considered.
How does endometrial cancer typically present, and what does the initial evaluation involve?
Most present with postmenopausal bleeding or AUB. Often early stage, no other symptoms fortunately. Eval, transvaginal ultrasound, endometrial biopsy, or hysteroscopy DNC if office biopsy difficult. Pelvic MRI for apparent early stage if considering fertility-sparing hormones. For advanced stage, 15% symptoms findings have spread. Add abdominal pelvic CT. Most common type, endometrioid adenocarcinoma, less aggressive. Others, serous clear cell carcinosarcoma, higher risk metastasis recurrence, poorer survival.
And treatment for early stage disease. Minimally invasive approaches seem common now.
Indeed. Total hysterectomy and BSO via minimally invasive techniques generally best for early stage. GOG LAP2 study showed improved surgical outcomes, shorter stays with laparoscopic versus open, similar survival. Robotic approach increasingly used, lower conversion rates than traditional laparoscopic, especially BMI 35.
What about surgical staging? That's evolved significantly too.
It has. Bilateral pelvic para-aortic lymphadenectomy plus intraperitoneal METS check are key staging components, though survival benefit debated for all. Low-risk patients, Mayo criteria, grade 1 to 2 endometrioid equals 2 centimeters, 50% invasion, no extrauterine disease, lymphadenectomy not advised, very low METS rate. Sentinel node biopsy increasingly used for early stage not meeting Mayo criteria, undergoing hysterectomy BSO. Inject dye, blue indocyanine green into cervix, trace to nodes, pelvic iliac, presacral, periaortic, excise sentinel nodes subject to ultra-staging detailed path analysis. Over 80% nodes identified, 95% sensitivity, 99% NPV, 2% false negative rate. Very effective.
So when is a full lymphadenectomy still performed?
Full pelvic para-aortic lymphadenectomy for early stage not meeting Mayo criteria if side-specific sentinel node not identified or SN biopsy capability absent. Pelvic scope, nodes lateral medial external iliac artery vein, bifurcation to deep circumflex obturator space. Periaortic scope when done. Lateral common iliac aorta, bifurcation to at least IMA, higher for high risk. Extensive extrauterine disease, cytoreductive surgery, remove max tumor, like ovarian cancer. Rarer uterine cancers, sarcoma, etc., generally don't need routine lymphadenectomy unless obvious nodal mets.
That's a deep dive into uterine cancers. Now let's explore the common uterine surgical procedures themselves, starting with hysteroscopy, dilation and curettage, DNC, and endometrial ablation.
Hysteroscopy, small telescope into uterine cavity, diagnostic or operative. Diagnostic, often office, paracervical block light anesthesia. Operative, usually OR, general regional anesthesia. Technique, speculum, tenaculum on cervix for gentle retraction, flattens curve.
Yeah.
Gentle dilation, distension media, normal saline usually, except bipolar current. Hypotonic, lysine mannitol for monopolar current.
And the visualization. How do you see everything?
Scope passed under direct visualization with distension media running. Speculum often removed. Cavity distends. See fundus tubulostia lower segment cervix. Operative hysteroscope allows instruments, scissors, graspers, electrosurgery for resection biopsy.
Then, often after hysteroscopy, the DNC or global sampling.
Yes. After scope removed, curette pass to fundus. Gentle curettage all four surfaces, tissue to pathology. Operative hysteroscopy directly treats pathology under view, common. Directed biopsy polypectomy, myomectomy, lysis of Senecae adhesions, endometrial ablation, hysteroscopic polypectomy, various instruments, forceps, scissors, morcellator, electrode snare, uterine adhesions, scissorsley scar tissue connecting walls.
An endometrial ablation for heavy bleeding.
Destroys endometrial lining via heat cold. Traditional hysteroscopy with roller ball loop electrode coagulates sex sizes lining to the thallus layer. Modern, non-resectoscopic global devices. Disposable, less skill needed, no continuous guidance. Built-in safety controls heat cold spread, requires seal detection. Very safe.
Next, myomectomy. Uterus-preserving fibroid removal. Can be done several ways.
Open, laparoscopic, hysteroscopic, or vaginal. Depends on fibroid size, location, surgeon experience. Vaginal myomectomy for cervical intracavitary fibroids protruding through cervix. Often large stalk. Hysteroscope confirms attachment, primary risk. Uncontrolled bleeding from stalk can retract. Bleeding reduction methods. Lateral sutures, 39 o'clock, occlude lower uterine artery branch, dilute vasopressin injection in stalk, endoloop sutures around stalk, transect distal, transect sharp electrosurgery, unmanageable bleeding, hysteroscope W cautery or uterine packing balloon.
And for fibroids inside the cavity, but not protruding, hysteroscopic myomectomy.
Suitable for type 0, 1, some 2 fibroids, needs experienced hysteroscopist. Methods: electrosurgery, loop shaves fibroid to base, monopole dipolar, hysteroscopic morcellation, suction draws fibroid to morcellator, cuture moved in segments, tissue collected for path.
Fluid management seems critical here. We mentioned safety limits.
Absolutely critical safety parameter. Monitor intrauterine fluid deficit. Isotonic, saline-LR, usually with bipolar. Hypotonic, lysimannitol, with monopolar, higher risk. Fluid management system measures in out. Guidelines. Max deficit 2500 cc isotonic, 1000 cc hypotonic. If limit reached, must terminate procedure. Non-negotiable safety rule. Repeat later if needed.
What about laparoscopic and open myomectomy for larger, deeper, or subserosal fibroids?
For types 3 to 8, similar steps regardless of approach. Preoperative planning most important. Exam, imaging, MRI preferred detailed location, number, vascularity, labs help decide approach, plan incisions, review feasibility risk. Intraoptot, examine anatomy, note orientation. Uterine arteries run laterally, so hysterotomy incisions medial. A nexa location helps guide if distorted. Inject dilute vasopressin into serosum myometrium over fibroid until blanching constricts vessels. Incise sharply monoharmonic through serosum myometrium to capsule. Grasp fibroid, tenaculum clamp. Dissect from myometrium, blunt mono sharp harmonic, avoid cutting healthy muscle. Maintain hemostasis, cautery suture.
And closure after the myoma is completely dissected.
Close myometrial incision with delayed absorbable suture, multiple layers by depth, no dead space. Final serosal layer approximates edges, achieves hemostasis. Critically, place adhesion barrier over hysterotomy before abdominal closure. Prevents post-stop adhesions.
Are there additional hemostatic measures for these larger procedures?
Yes. Rectal misoprostol, 400-800 milligrams prior to incision, induces uterine contraction, tamponade. Intraoperative tourniquet. Open Penrose drains feeding tubes around lower segment after opening broad leg. Lap temporary vascular clips clamps, bulldogs, on uterine ovarian vessels. Tourniquet duration equals 90 minutes, 10-minute rest between replacements.
And critical post-myomectomy counseling,
Yeah.
especially rehitter fertility.
Paramount. Counsel on future childbearing plans, risk of uterine rupture rare but serious, labor options. Wait 3 to 6 months before conceiving if significant incision. Avoid trial of labor if 50% myometrial invasion. Planned C-section often recommended.
Now, the surgical removal of the uterus itself, hysterectomy, one of those common gyn surgeries.
Roots, open, vaginal, minimally invasive, lipobotic. Consider components to ovaries, corpus only, cervix, upper vagina included.
Let's start with total abdominal hysterectomy, the open approach. Key steps.
Removes corpus plus cervix, abdominal incision, low transverse vertical midline based on factors. Initial steps. ID anatomy, node abnormalities, grasp round ligaments laterally, divide cautery suture medially. Incise anterior broad leg medially toward internal os, facilitates bladder flap, separates bladder. Adnexa removal, incise posterior broad leg, make window below adnexa, ID ureters. Isolate tubular ovarian leg. Double clamp ovarian vessels, incise. Double suture ligate superiorly. Ligate specimen side, prevent back bleed. Adnexa spared, 2 straight clamps across uterine ovarian vessels, divide a double ligate superiorly.
Then focus shifts to uterus cervix itself.
Yes. Incise remaining posterior broad lib inferiorly, skeletonized uterine vessels. Dissect bladder off cervix, sharp cautery. Retract inferiorly. Curved clamp across uterine vessels at internal os cut, suture ligate. Dissect bladder completely below cervix. Place straight Haney-Zeppelin clamp on remaining cardinal uterosacral ligaments serially bilaterally. Cut pedicles, suture ligate, freeze uterus.
And how is the vaginal amputation and cuff closure handled?
Several methods. 1. Curved clamps across vagina medial to prior pedicles, just below cervix. Cut above clamps. Running delayed absorbable suture over-under clamp, pull tight, tie midline run imbricating layer laterally. 2. Haney transfixion stitches ligate vaginal corners beneath clamps. Interrupted figure eights close midline. 3. Direct sharp incision into vagina below cervix. Extend around cervix. Grasp upper vaginal edges, Alice clamps. Close colpotomy, running interrupted figure eights. Crucially incorporating ipsilateral uterosacral ligament for apical support with lateral apex sutures.
Prevents prolapse.
How do minimally invasive hysterectomies, laparobotic, compare? Fundamental steps similar. Key difference. Pedicles secure divided with electrocautery vessel sealing cutting devices, not clamp suture. Lap port placement varies. Typical. Umbilical, bilateral, lower quad, suprapubic upper quad. Large uterus, higher, more ports. Camera usually umbilical, 030 scope. Robotic, similar morbidity for benign, higher cost. Trocar placement per guidelines. Crucial aid from vaginal side. Uterine manipulator with colpotomizer cervical ring. Key for ideating fornices, avoiding urinary tract injury, delineating colpotomy.
And colpotomy and delivery in minimally invasive.
Once vessels ligaments divided, colpotomy completed along colpotomizing with monopolar energy, endocervic. Uterus, cervix, adnexa usually delivered through vagina. Place sponge-filled glove the pneumocluter balloon into vagina, prevents CO2 egress. Close colpotomy, running absorbable barbed suture. Alternatively, close cuff vaginally, interrupted figure eights.
What about vaginal hysterectomy? One of earliest surgeries, steps largely unchanged. Fascinating.
Testament to effectiveness. Order opposite abdominal lap. Colpotomy first, corneal pedicles last. Patient high lithotomy. Hemostasis. Inject cervix uterus synchrols with dilute vaselido plus epi. Grasp cervix, tenaculum. Circumferential incision around cervix where epithelium merges, sharp cautery. Posterior dissection. Grasp posterior fascia, traction down. Enter posterior cul-de-sac sharply, extend laterally, ID uterosacals bilaterally. Clamp, incise off cervix, ligate, tag for later.
And then the anterior dissection.
Long-weighted speculum into posterior cul-de-sac. Lift anterior vaginal epithelium, dissect bladder off cervix to peritoneum. Incise anterior peritoneum sharply. Right angle retractor through incision retracts bladder anteriorly. Serial bilateral steps. Curve clamp, laterally clamps divides, ligates cardinal ligaments, uterine vessels. With each pedicle, uterus delivered further down. Final pedicles. Corneal structures, round lig, tube, uterovarian lig. Clamp across cornua under direct view, include all, avoid bowel. Cut pedicle inferiorly, freeing uterus cervix. Double ligate, inspect hemostasis, allow retraction. Similar if ovary tubes removed, clamp ovarian vessels.
And finally, closing up from vaginal hysterectomy.
Examine pelvis for hemostasis at pedicles. Grasp colpotomy edges, include peritoneal layer. Angle stitches first, incorporating tagged uterus sacrals for apical support. Close remainder horizontally, running, figure 8, interrupted.
We also have supracervical hysterectomy, subtotal, leaving cervix in place.
Removes uterine corpus only. Open or minimally invasive. Same steps as total up to uterine artery ligation. Ligation occurs at internal cervical os level. Amputate uterus body from cervix, sharp surgery. Remaining cervical stump may need oversuturing for hemostasis.
And two important related considerations, elective BSO and opportunistic self-injectomy.
BSO can be done with hysterectomy, but only clear indications. Elective BSO, SBs 45, carries increased long-term cardioneuromorbidity mortality, surgical menopause. Opportunistic full self-injectomy tubes only, now increasingly recommended at hysterectomy sterilization, potentially reduces risk of fallopian tube high-grade serous cancer, significant shift based on cancer origin understanding.
And one last crucial safety measure, post-operative cystoscopy. Many gyn surgery orgs advocate immediate post-op cystoscopy. Assesses bladder root integrity. Easily done. 70-degree scope, sterile fluid. Remove catheter past scope. Distend bladder fully. Visualize dome. Assess for suture, foreign body, lesions, defects. Monitor both ureteral orifices for adequate urine flow, jets. Increases intraop detection of urinary tract injuries, allows immediate repair.
Finally, let's revisit sentinel node biopsy and lymphadenectomy for endometrial cancer, critical to uterine procedures.
Right. Sentinel node biopsy, emerging preferred strategy. Mitigates full lymphadenectomy complications for early stage not meeting Mayo criteria, undergoing histo-BSO. Inject dye, blue into cyanine green, superficially deep into cervix, 39 o'clock. Trace to nodes, pelvic iliac, presacral periortic,
Right.
XI sentinels subject to ultrastaging, detailed path, over 80% ID'd, 95% sensitivity, 99% NPV, 2% false negative.
And pelvic and periaortic lymphadenectomy when still indicated. For early stage not meeting Mayo criteria, if site-specific sentinel not ID'd or SN biopsy capability absent. Pelvic scope, nodes lateral medial external iliacs, bifurcation to deep circumflex, obturator space. Para-aortic scope, when done. Bilateral lateral common iliac aorta, bifurcation to at least IMA, higher for high risk.
We've covered a remarkable amount on uterine diseases and procedures. Now let's move to the fallopian tube and ovaries, starting with their common surgical diseases.
Okay, one significant area, managing BRCA mutation carriers. Germline mutations in BRCA12 significantly increase lifetime breast ovarian cancer risk. By age 70, BRCA1, 57% breast, 40% ovarian, BRCA2, 49% breast, 18% ovarian. List of other genes increasing risk, BRIP1, R8051CD, mismatch repair, evolving. Guidelines exist for genetic counseling testing.
Management depends on fertility desire.
Yes, if fertility desired, intense screening or chemoprevention, completed childbearing. Risk-reducing salpingo-oophorectomy, RSO strongly recommended. Ages 35-40, BRCA1, 40-45, BRCA2. Reduces ovarian cancer risk 80%, breast cancer 50%, mainly BRCA1.
Another common situation, patient desires sterilization.
Female sterilization, most common method, married couples globally, 2X male. Crucial counseling, permanence versus equally effective LARCs, IUDs, etc. Historically, race, ethnicity, SES, affected counseling need universal respect for autonomy. Male sterilization, less risk, more effective. Tubal failure, 2%. Regret, 14%. Higher risk, women of color, young age, decision at abortion C-section.
Next, gynecologic emergency, ectopic pregnancy.
Rate, 1-2% live births, 90% in fallopian tube. Risks, prior ectopic, PID, infertility, IUD use, smoking, prior tubal ligation, presentation, nonspecific pain, vaginal bleeding, exam, tender abdomen, cervical motion tenderness, adnexal mass, ruptured ectopic emergency, hypovolemic shock, diagnosis, quantitative HCG plus transvaginal ultrasound, high sensitivity of tubal ectopic doe, heartbeat, or inhomogeneous mass.
Management, medical, methotrexate, stable patients, or surgical, unstable, failed medical contraindications.
Then there's torsion, ovarian, another critical emergency. Ovary plus mock tube, twists on attachments, compromises blood supply, 3% gyn emergencies, most common reproductive age. Risk factor, ovarian cyst tumor, prone to twisting. Presentation, acute onset, sharp unilateral pelvic pain plus nausea. Signs, unilateral pain, adnexal tenderness. Diagnosis, transvaginal Doppler US, enlarged ovary, twisted pedicle, diminished flow, but flow not always absent diagnosis based on clinical suspicion. Warrants immediate surgery, diagnosis often confirmed interop, detorsion, untwisting, procedure of choice, 80% normal ovarian function post-procedure. Cystectomy may accompany if EPS present. Recurrence risk small. Oophoropexy not proven to reduce risk.
What about an endometrioma, the chocolate cyst?
Ovarian cyst associated with endometriosis, tissue outside uterus. Contains dark brown, thick, tarry fluid, old blood. Most patients reproductive age. Often present with endometriosis symptoms, pain, dysmenorrhea, dyspareunia, infertility. Some asymptomatic. Exam, painful adnexal mass, other endometriosis signs, cul-de-sac nodularity. Diagnosis, transvaginal US, unilocular cyst, low-level echogenicity, ground glass feature. Management, medical for presumptive endo or surgical. Larger endometriomas, 4 centimeters, usually refractory to medical. Laparoscopic excision treatment of choice. Concern rates ovarian reserve damage, but excision preferred over drainage for pain and fertility suspicion of neoplasm.
And the broad category of benign ovarian masses.
Most are functional cysts. Follicular corpus luteum, normal cycle occurrences, asymptomatic, rarely 5 centimeters. Common benign neoplasms. Cystic teratomas, dermoids, hair teeth. Serous mucinous cystadenomas fibromas, solid fibromas fibrothecomas, many asymptomatic, some pelvic pain pressure, exam, smooth, mobile, various sizes, rarely ascites, eval transvaginal US, size features distinct findings, select tumor markers, CA125, HCG, AFP, LEH based on scenario malignancy concern, management, functional cyst conservative observation symptom management, suspected benign neoplasm surgical intervention, usually laparoscopic, lapovarian cystectomy for dermoid fibroma 10 centimeter, preserve ovary, oophorectomy often needed for larger dermoid cystadenomas replacing ovary, laparotomy for very large equivocal diagnosis or refractory TOA, gyn on consult for suspected cancer complex surgery.
Finally, for ovarian diseases, malignant ovarian neoplasms. Serious, often advanced presentation.
Originate from germ cells, stromal cells, or epithelial cells, ovary tube. Diverse group. May present subtly, bloating, pain, early stadium, urinary symptoms. Challenging early diagnosis. Germ cell stromal epithelial. Pain, adnexal mass, no obvious mets. Advanced epithelial majority. Abdominal distension to sites. Carcinomatosis on exam from nodular fixed pelvic mass. High-grade serous, most common aggressive, now thought to originate in tube. Diagnosis, CT chest abdo-pelvis plus tumor markers. Germ cell younger. HCG, LDH, AFP, epithelial older. CA125, CEA, CA19-9. Stromal, inhibin hormones. Exclude Met's recent breast colon screening results, age 40 plus.
And treatment approaches. Debulking seems key.
Primary surgical debulking plus staging. Traditional, preferred for clinical early stage. Fertility sparing possible, germ cell, low-grade epithelial. Advanced stage, considered if fit and optimal reception likely, 1 centimeter residual, preferably none. Recent studies. Neoadjuvant chemo plus interval debulking, chemo first 3-4 cycles, then surgery, gives similar outcomes, less morbidity for advanced stage if optimal debulking unlikely upfront, or patient high risk. Clinical factors laparoscopy guide decision, recurrence, secondary later surgery may benefit select patients, long tumor-free interval, isolated disease, no ascites.
That brings us to the common fallopian tube ovarian surgical procedures. Let's start with tubal sterilization.
Most commonly laparoscopic, also minilap or transvaginal, partial salpingectomy techniques, Pomeroy modified Pomeroy, lift midrib loop, Babcock, ligate loop, absorbable suture, excise 1 to 2 centimeter section, Parkland, lift mid-tube, make window and mesosalpinx, ligate 2 centimeter portion proximal distally, excise. Specimens always sent for path confirmation.
And the increasing trend of opportunistic salpingectomy.
Significant shift, increasingly done at tubal hysterectomy. Rationale, potential to reduce risk high-grade serous carcinoma originates in tube. Technique, elevate tube, windows and mesosalpinx, ligate cauterized vessels, excise entire tube at cornu, other techniques. Mechanical clips rings, cauterization. Rings have slightly higher failure morbidity than clips. Bipolar cautery, ensure 2 centimeter mid-tube cauterize.
Next, salpingectomy, salpingostomy for ectopic pregnancy.
Surgery required if fail medical or acute rupture. Laparoscopic preferred, even with large hemoperitoneum. Options, partial salpingectomy, remove segment, or salpingostomy, incision remove pregnancy, leave tube. Trials show no different subsequent ectopic IUP rates. Partial salpingectomy preferred if severe tube damage or significant bleeding. Technique mimics tubal sterilization, elevate, cauterize, incise, proximal distal, divide, mesosalpinx, send specimen for path.
And salpingostomy, when preferred.
For unruptured ectopic, desiring fertility, contralateral tube damage or removal would require IVF technique. Inject vasopressin, linear incision over ectopic, flush out products. No suture needed, heals secondary intention. Post-op, monitor serial HCGs to ensure resolution.
For ovarian emergencies, ovarian detorsion.
Laparoscopic preferred. Direct view confirms diagnosis. Twisted ovary tube, edematous, dark, may seem non-viable. Procedure of choice, detorsion, untwisting. 80% have normal function post-op, even if looked bad. Cystectomy may accompany if cyst present. Recurrence risk small. Oophoropexy not proven to reduce risk.
Ovarian cystectomy. Removing cyst, preserving ovary.
For endometrioma, torsed ovary cyst, benign neoplasm, cystadenomatermoid, borderline tumor, best for patients wanting fertility, residual normal ovary visible. Indicated endometriomas 4 centimeters, improves fertility versus drainage. Borderline tumors, higher recurrence versus SO, but survival not compromised. Laparoscopic preferred usually. Technique, incise ovarian surface over cyst, mechanical hydrodissection, excises mass completely, cautery for bleeding. Endometrioma excision difficult, reserve often compromised.
Finally, salpingo-oophorectomy, unilateral or bilateral, tube plus ovary removal. Indications. Benign mass involving entire ovary, RRSO, BRCA, chronic pain, severe endoadhesions, malignant neoplasm, usually laparoscopic, laparotomy for extensive prior surgery adhesions, large difficult mass, suspected malignancy, refractory TOA.
Technique and safety.
Quadrizeligate ovarian vessels proximal to ovary tube, uteroneovarian vessels distal. For RRSO, ligate ovarian vessels well above ovary tube, avoid residual tissue. Abdopelvic washings. Aware 5% BRCA have occult cancer. Key safety. ID structures. Ureter most important. Near ovarian vessels at iliac bifurcation. Lift adnexa anteriorly away from ureter before cautery ligation, if hindered. Ureterolysis. Retroperitoneal dissection. Carefully lease bowel adhesions. Aware of external iliac vessels, incising posterior broad leg helps develop space, separate adnexa, ID ureter. Our final deep dive procedure, fallopian tube ovarian cancer cytoreduction, complex, crucial for survival.
Early stage, 10-15%, apparently confined to ovary, more common, germ cell, stromal, some epithelial. Goal: remove affected ovary, contralateral uterus if appropriate. Staging crucial. Washings, peritoneal biopsies, omentectomy, pelvic para-aortic lymphadenectomy, fertility hormone preservation possible for Guillain-Barré germ cell.
An advanced stage, majority epithelial.
Usually pelvic mass, omental mets, carcinomatosis, ascites. Goal: optimal site reduction, 1 centimeter residual, preferably none. Best outcomes, no residual. Paradigm shift. Historically primary debulking chemo. Now, neoadjuvant chemo interval, debulking similar outcomes, less morbidity SCP if optimal debulking unlikely upfront or patient high risk. Clinical factors, laparoscopy, predict feasibility, recurrence, secondary later surgery may benefit select patients, long interval, isolated disease, no ascites.
How is cytoreduction surgery phased?
Approach: primary interval, usually midline incision open. Minimally invasive, possible select early interval cases. Phased goals. Phase 1, pelvis. TAH, BSO, or en bloc resection. Sigmoid pelvic peritoneum if extensive involvement. Often retroperitoneal approach, bilateral urinalysis, bladder dissection. Colon divided, stapler, anastomosis feasible. Phase 2, upper abdomen. Resect involved omentum, gastrocolic and furcolic. Avoid injury stomach, colon, spleen, pancreas, liver. Diaphragm disease. Divide falciform, mobilized liver, strip peritoneum, resect obliterate isolated nodules, small bowel resection occasionally needed. Phase 3, nodal mets. Remove obvious nodal mets. Needs retroperitoneal exposure. Elective nodal resection in advanced ovarian without clinical involvement does not improve outcomes. Avoid targeted approach.
What an incredible journey through the intricate world of gynecologic surgery. From the minute details of vulvar anatomy to the complex decision-making for diseases like endometrial cancer and that incredibly challenging ovarian site reduction. This deep dive has truly provided a comprehensive and what I would call a professional level understanding.
Yeah, our goal was really to equip you, our listener, with this invaluable knowledge. We hope it allows for a much deeper appreciation of the human body and the remarkable precision of modern medicine, giving you that curated shortcut to understanding. You now have the foundational understanding to not just be informed, but truly well informed in this critical area, recognizing the complexities and the advancements that shape patient care.
And as advancements continue to push the boundaries of surgical intervention and our genomic understanding, like with BRCA mutations revealing genetic predispositions, how might the balance between individual autonomy and evolving medical recommendations continue to shift? What further ethical considerations or patient choices might emerge from even deeper dives into personalized medicine as we learn more about each individual's unique biological blueprint? It's a field that never stops evolving, and neither should our understanding.